Hello, everyone. Good morning. Thank you all for joining. And we are waiting for more attendees to join the call. So, if any of your friends are waiting to join or didn't join yet, please ask them to join. And don't forget to drop reminders in your groups, office groups, personal friend groups, or in LinkedIn. Please post so that we can get started on time with good crowd and good interaction. We will be starting our session by 10 o'clock. Maybe like we may give 5 or 10 minutes more for everybody to join. So please drop reminders in the group. అవును. దాంట్లో అది ఇల్లు ఆయన. ఇప్పుడు చేసుకుంది.
Funny, you are not on mute, Funny.
అంటే అడుగుతుంది.
We will give couple of minutes to attendees to join the call. See a lot of attendees they are joining. So we'll give couple of minutes, then we can start the session.
Okay, members, I would request everybody not to drop your AAPC details in the chat box. Do not post anything in the chat box except your questions or interactions with others. That's it. Please do not post your AAPC details in the chat box. The details will be auto captured from the registration form that you have already filled. So you don't need to drop your details again. So please do not drop your details in the chat box. Thank you.
Shall we start, Fanny?
Yeah, sure. Just a moment, Madhuri.
Madhuri, I still see people joining in. Do you want to give another couple of minutes for everybody to join?
Yeah, sure, Adi. We'll give couple of minutes and we
Yeah,
can start.
I'm just seeing that people are still joining in.
Okay.
Exactly at 10:10 we will start.
Sure, Adi. We'll start by 10:10. We'll
Thank
give
you.
couple of minutes to join the call.
So meanwhile, the people who have joined, we may have a lot of freshers and also experienced coders, but the main question that we are keep on getting is while filling the form. So how do we know our local chapter? Like what we have to fill in the current local chapter. So this is a common question that we are getting. So to find your assigned local chapter, you will have to open your AAPC profile. Like you need to log in and go to your profile and preferences, and you will see your personal details and experience details, and also a local chapter tab over there. So from there, you will have to uh, fill the detail. Like if your chapter is showing as Chennai over there, you should mention as Chennai. If it is Hyderabad, mention as Hyderabad. So it should be in that way. And if you would like to subscribe to new chapters also, like you're not from Hyderabad chapter, but you want to receive updates for Hyderabad chapter events also. So in the same tab, you see an option to subscribe for the other chapters. You can select Hyderabad over there and you can subscribe for it. And whenever there is an event from Hyderabad, you can get the details, and you can enroll for those chapter events. Okay, so that is how you'll have to fill the details. And I request again, everybody, please do not drop your AAPC details in the chat box. We do not need your details from the chat. Like we won't take it from the chat box. We will be taking the details in the registration form that you have filled. So whenever you are filling your registration form, please ensure that you fill it with utmost accuracy. Your member ID, your name, your registered email ID are very important for us to credit the CEUs. Okay, and you need to be there till end of the presentation to get eligibility for the CEUs. Okay, thank you. Okay, am I audible now?
Hi.
Yeah. So, good morning, all. Hope you are all able to hear me. If I am audible to you, please give thumbs up. Yeah. Thank you for the reaction. So, yeah. Wow. So, good morning, everyone. Again, welcome to today's AAPC local chapter virtual meeting. And I am Goli Saifani, your member development officer. And it's truly pleasure to see many familiar and also new faces joining us on Sunday morning to learn, grow, and connect as community. Special welcome to our new chapter members and big congratulations to everyone who recently got certified. So without further ado, I'll be handing it over to our chapter president, Adilakshmi Shankara, to introduce our speaker. Over to you, ma'am. You're on mute. We can't hear you.
Adi ma'am, you're
Am I
on.
audible? Am
Yeah.
I audible now?
Yes.
All right. Good morning, everyone, and happy Sunday, all of you. And the day begins with the learning, and I think it's a great going. And I see a lot of many people joining in here today. Welcome everybody, all the attendees, for a very joyful learning session. So I would like to, first talk about something about, today's event. So this is not a regular learning that what we see today. So though we have more than 3 lakhs coders across the state and or a couple of states, we still have very few coders who are home health coding certified, who are excelling in home health. But we always think, what is this home health? What specialties and what skill set do we need to get into the home health? So I think this is going to be an eye-opening session with a very well-known subject matter expert, a leader in home health coding, who's been with home health coding for many years now, and who've been empowering and sharing the knowledge, making people certify in home health coding for many years now. So I take this opportunity to welcome our speaker, Mr. Srinivas, today, who's also our chapter officer, who came in forward to share his knowledge to make people aware what home health coding is all about. I think the layer or the questions that what we all have about home health coding. Can I become a home health coder? What is it about home health coder? How complex it is? Now, I think it's time for us to reveal all those details here. Guys, please pay attention, not just getting your CEUs, but also unveiling all your questions. All right. With this, I would welcome Mr. Srinivas. Srinivas, please go ahead, and my hearty welcome to you. Thanks for taking this initiation to make people aware about home health coding and the certifications. And guys, please pay attention. If you have any questions, I would suggest please park your questions for the end of this session. And Srinivas will be here for all of you to answer all your questions. And I'm here to answer any of your questions as well. All right. Welcome, Srinivas, and over to you.
Good morning, ma'am, and good morning, everybody. Thank you so much, ma'am, for your kind words. There's a lot of support that I got from you and from the overall our local chapter. Thank you so much for the kind words. Let me share my screen and we'll get started, and we'll see what are the questions that are coming in our way. Thank you. So, so can you see the screen?
Yeah, we can see it.
And you can see the screen, right? So thank you. Today is understanding home health coding. So, the background is very simple, that we'll try to understand what exactly is home health coding, who are all eligible, maybe a fresher who want to get into home health coding, or an experienced person or a coder who want to transition into home health coding. So we're going to give you a very good idea how it runs, what are the different aspects that are involved in the home health coding. That's the agenda of this particular meeting. So etiquette of this particular meeting. So I think please be attentive. That's the only request I have for you. And because we are in the medical professional related to healthcare profession, so I just want to mention two of the significant events that have happened in the history on the day March 23. So there was a discovery of the structure of insulin. So the person who has done it, Frederick Sanger, and he was awarded a Nobel Prize in chemistry. So that was way back in 1950s. And we all know, probably from our 8th standard, 9th standard, we would have heard about Pierre Curie. He was the person who was a co-discoverer of radioactivity. He was passed away on this date on 1906. So these are the significant events in different years, so back in the history. So now the agenda of this meeting is we will try to understand introduction to home health care, what is a home health agency, eligibility for home health coding. So this is where we'll be having a lot of discussion. Levels of home health coding, and what are the different challenges. We listed out few challenges that we are facing in the home health coding. So this is about the agenda of this particular meeting. So I'll start with introduction of the home health care. Now, before we see the classical definition or the textbook definition of the home health care, I want to give you a broad understanding how the home health care actually works and what exactly it is. So we have been using this home health care term in the last few minutes many a times. So by this time everybody would have understood that there is something, some kind of a service that has been provided in the home. So the name itself is indicating that, okay, home health care, definitely there is a home involved. Yeah, that is for sure. So because the services are delivered in the patient's home. So that is one of the key aspects of the home health care. Now, if we are working maybe IPDRG or a risk adjustment coding or an emergency department, so we are basically looking what is exactly happening with the patient in the healthcare setting, specifically the hospital or maybe a psychiatric facility or a skilled nursing facility or inpatient facility. So these are the hospitals or different facilities that are available. But in the case of home health care, what happens is there are services that have been provided in the home. So that part we are going to discuss in the next few minutes. Now, what is this introduction to home health care? Now, I'll give you a very simplistic definition. Home health care is a specialized form of care that is delivered in the patient home, be it a medical or non-medical care, for the patients who are recovering from an illness or an injury, maybe a surgery, or the patients who have long-term conditions like diabetes, hypertension, maybe a stroke-related hemiparesis. So the patients are basically recovering in the home health or in home, and the services have been provided at the home. Now, overall involved in this particular home health care, or what are the key features? Now, in the case of home health care, the care is being delivered, or tailored for a particular patient. So if a patient is recovering from a stroke, definitely there is a different services or a particular services that should be provided. So the personalized care is one of the key aspects of the home health care. So every patient, if you have 100 patients may not require the same kind of healthcare services, be it in the hospital or in the home. So this is a tailor-made kind of service that they are going to provide in the home. The next thing is cost effective. Now, cost effectiveness is coming from this particular home health care because the patient is in the home and they are getting the services in the home. Now, if imagine a person being in the hospital for a very long time, maybe 60 days, 90 days, or maybe 4 months or 5 months. So there's a definite cost involved when you compare with the home health care services that are provided in the home. the cost of the hospital is definitely high. So this is cost effective. The next thing is comfort and convenience. Now, home health care is, many of the times is for the individuals who are over 65 or maybe 70 or 80. So we are basically looking at the people who are more than 65, the older people or elderly people. Now, for them to be able to be in the hospital is a journey. Now, when they are in the home, they'll have the comfort and convenience. Now, let us take an example like, okay, there is a patient who is 70-year-old, suffered a fracture. So rather than being in the hospital, that particular patient want to be in the home and get the service so that they are familiar in their home environment. They can walk, they can go to, they can take a walk in their, own home. They know where exactly is the washroom or where exactly is, the stairs. So they will be able to manage themselves effectively because there is a factor of convenience and the comfort. So that is the third critical aspect or key feature. Now, there's a fourth one, that is promotes independence. Now, what are we talking about independence? Now, for example, home health care is not only service delivery, there is an education attached to it. Now, patient is recovering from a hemiparesis because of a stroke. So definitely the services are provided. A physical therapist will come to the patient and give the service. But along with that, they'll educate the patient and the caregivers in the home so that the patient will become independent. Maybe it may take some time, but because of the education that has been given to the patient and the caregivers, so there is a definite promotion of the independence. So the patient wants to walk, the patient will take some XYZ steps to walk, while being paralyzed. So that is where it promotes independence. And finally, the interdisciplinary approach. Now, what is this interdisciplinary approach? So what I'm trying to tell you that there are a lot of people involved in the home health care, or when we are giving service to a patient. There is a doctor, definitely, yes. There's a home health agency. There are clinicians. Now, these are all the people, and along with the family members or a caregiver. So these are all the people who are going to give a regular feedback to the doctor or the physician, and the physician will make a right decision to be able to provide the right care for that particular patient. Now, this is an interdisciplinary approach. We are getting the feedback from almost everybody who is involved in the patient service. Now, they will be getting together and understand what exactly is required for the patient to be independent, to recover quickly, and to be able to manage their tasks effectively. So these are the critical aspects of the home health care. Now, I'd like to list out very simply that this is a personalized care. I mean, there is a tailor-made service for every patient who wants to be in the home health care. Cost effective, promotes independence, comfort and convenience because the patient is familiar with the home conditions, and finally interdisciplinary approach. Now that we know a background about the home health care, who are going to take it, the next thing is eligibility, or everybody who is older may not be able to get the home health care. Now, who requires home health care or who benefits from home health care? That is one of the important things that we need to know. Now, who benefits? Definitely the people who are elderly and having ongoing medical care of assistance, maybe a chronic condition which is exacerbating, like COPD exacerbation. The patient is on the respiratory rehab. Now, these patients are requiring home health care more than anybody else. Then recovering from a surgery. No, there is a surgical wound. The patient may not be able to care for the surgical wound, and definitely a skilled nurse will come to the patient and they are going to do the dressing changes, and required services will be provided. Now, people with multiple chronic conditions, there is a element of uncertainty because there are a lot of chronic conditions. The patient is using multiple medications. Now, medication administration is also one of the important aspects of the care, because if you're taking a wrong medication, maybe it may lead to adverse effect or a poisoning kind of a thing. So that is the reason medication administration for the people with multiple chronic conditions, along with some acute conditions, of course. But the people with multiple chronic conditions, you have to be very, very, very careful, because the administration, the medication, there is an interaction, and all this stuff will be given by the the clinicians who are visiting the patient. And finally, people with disabilities who need long-term support. Yes, maybe there is a below the knee amputation, because of some gangrene. So they need home health care, more than anybody else. So that is the reason the benefits or the beneficiaries of the home health care are people with multiple chronic conditions, recovering from a stroke or recovering from a surgery or a disability. So that is the background of the home health care. Now that we know what is home health care, so we are going to see what is the classic, understanding of the home health care. So home health care refers to medical services provided in a patient's home for individuals who are homebound due to illness, surgery, injury, or a chronic health conditions. It focuses on delivering essential medical care, rehab, and support to help patients recover or manage their conditions while remaining in a familiar environment. Now, this is what we have seen. So there is a familiarity. That is the reason most of the older people are looking for home health care. Now, I'll get into the eligibility aspect probably in the next few slides, because everybody who is older may not be able to be, getting the home health care. So the eligibility criteria is a bit different. Now, I am older as a patient. I'm older, like I'm 70, but I need home health care. So that's what the doctor will decide, not the patient. So patient preference or willingness is not going to be considered, because there are a lot of criteria involved. The patient has to get a home health care. So definitely there are a lot of people involved, maybe the clinicians or the physicians and the home health agency to decide. Now, the primary objective of the home health care is to ensure patients remain safe and comfortable in their homes while reducing the need for hospitalization. It focuses on providing medical care, monitoring health conditions, and supporting recovery to enhance overall well-being. Now, let us take an example. So the patient is in the home. Definitely, there is some safety that is attached to it. Yes, because the patient in the home has familiar conditions in the home. Now, this is very, very important. Home health care always looks at the safety as a parameter rather than doing some tasks and injuring the patient and all this stuff. That is not going to be the primary goal. The primary goal or the objective of the home health care is to ensure patients are remaining safe in the home and comfortable in the home and recovering quickly because of the familiar conditions and because of the service that has been provided to the patient in the home. Now, home health professionals deliver care to manage illness, support recovery, restore health, and promote independence, enabling patients to remain safely in their homes. Now, we discussed just before that managing illness. Okay, there are multiple chronic conditions. Patient is taking, maybe 10 prescription medications. There is some OTC. There's oxygen that is required for the patient. Now, this is where the patient will get confused because of the age, maybe a lot of medication that the patient has to manage. So that is where the home health clinicians will comes into picture, and they'll be giving the medication administration, maybe the chart. They'll prepare a diary when they have to take a medication, and what are all the maybe there is a medication interaction. So that also that will be taken care by the clinicians. Supporting recovery is one of the best example is recovering from a paralysis. Recovering from a paralysis, the patient suddenly had stroke, and that resulted in a left-sided hemiparesis or a right-sided hemiparesis. So definitely, the recovery part will be taken care by the physical therapist. So they'll be supporting that and restoring health. Let's take example of the fracture. Now, what is restoration? So we have to make the patient what it was before. Now, what I mean by that is the patient suffered a fracture today. The patient went to hospital and patient is coming back home. So before the fracture, the patient was able to walk and independently do some of the activities. Now, after the fracture, the goal of the home health care professionals is that we have to restore the patient's walking. So that is the restoration of health. I mean, it goes like everything that has been hindered or altered because of some condition. The home health care, the professionals will have a goal, or they'll set the goal that this patient should be restoring health in terms of walking, in terms of maybe a diabetic exacerbation should be completely stable, and promote independence as we have seen, and enable patients to remain safely in their homes. Yes, that is what it makes a home health care actually. Now, home health care typically involves a team of professionals, including skilled nurses, physical therapists, occupational therapists, speech language pathologists, or a speech therapist, who work together to provide comprehensive patient care. Now, there are there is a definitely doctor involved, the physician involved, who will be giving an idea of what exactly is happening with the patient and what are we going to do with the patient. But doctor is not going to visit the patient in the home. So definitely the clinicians will visit the patient based on the requirement. So there are skilled nurses, physical therapists, occupational therapists, SLPs, that is speech language pathologists, and speech therapists. Now, every professional has a different role to play. Now, the patient is recovering from a surgery. That is, a skilled nurse has to take care of that particular surgical wound, maybe a dressing change, prevention of the infection, antibiotic administration. This is the skilled nurse duty to make sure that the uh, patient is recovering from the surgical, or the patient is actually having a good healing as far as the surgical wound is concerned. Now let's talk about physical therapists. Physical therapists will take care of the strengthening, maybe the lower extremity strengthening. There is a fracture, there is hemiparesis, the physical therapist will come into picture. Now occupational therapists, they're going to take care specifically in the upper extremities. Maybe there is a muscle weakness, there is a fracture, or again the paralysis. Speech language pathologist or speech therapist is for the people who are having dysarthria, maybe not able to speak properly. So they'll give the training to the older people so that their speech might become clear or should become clear. That is the goal. So every there are a team of professionals, but everybody has their own kind of skill set to take care of the patients. Now, if there is a surgical wound, skill nurse will come into picture. They're going to, change the wound dressing. They're going to prevent the, they'll give you the education on how to prevent the infection. Now, before it becomes a complication of the surgical wound. So these are all the professionals that are involved to make sure that the patient is recovering nicely. Now, flow of the home health care. Now, okay, we have seen what is the definition, who are all involved. Now, let us see how the home health care, the cycle will run. So let's take a patient, homebound. Now, let me give you an idea about the homebound also. One of the key criteria is homebound. Now, as I told you probably in the last few minutes that everybody is older and they may not be able to be eligible for or able to get the home health care directly. So you are 70-year-old and you're not defaultly eligible for the home health care. Now, what are the criteria? There are different criteria, but the primary criteria that they consider as the physician or the team of professionals like clinicians is that the patient must be homebound. Now, if the patient is homebound, what does that mean? So, patient is homebound, the simple definition goes as the patient on their own may not be able to leave the home. So that means they require some kind of a support to be able to go out. Now, there is a misunderstanding, I'd say, as far as the homebound status is concerned. Now, when I say homebound, that means the patient is not going out on their own. Now, what does that mean? The patient can go out with the support. For example, the patient wants to go to a church, maybe an outpatient visit, or maybe visit a family member, visit a relative. That is absolutely okay. But the homebound status specifically indicates that the patient is not able to go out of the home. Now, this is one of the criteria that the physician will consider before making the patient or before giving the order for home health care. Now, let us see the flow. Patient who is homebound. So, for some reason, the patient visits hospital. Now, in the hospital, the treatment will be given by the physician and, of course, the team of the professionals over there. Now, once the patient in the hospital, let's take an example to make it a little easy to understand. The patient suffered a stroke. So the patient has been taken to hospital. Once the patient in the hospital, the physician will be directly involved with the care, the treatment that is being provided. Okay, it took around 7 days or 8 days to basically stabilize the patient. Now the patient is stabilized with the treatment at hospital. So they have given the required treatment for the particular stroke. But unfortunately, the patient has a maybe dysphagia or a right side hemiparesis. But the patient is stabilized. So now this particular time or period where the doctor has to decide whether this particular patient is eligible for home health care or not. Now, patient visits a hospital and there is a treatment that is been provided, and there is a stabilization is also done. Once the stabilization is done, now is it really required for the patient to be in the hospital? That is what is to be decided by the doctor or the physician. Now, okay, stabilization is done. There is a hemiparesis, but the patient is recovering. Now that the patient has taken the treatment that can be given in the hospital, the routine recovery can happen in the home. Now that is what the physician has to decide. Now the physician has decided that there, I mean, how do they decide? They'll see some of the criteria. Okay. So if the patient met the criteria for home health care, what happens is after meeting the criteria, the patient will be given the home health care orders. Once the home health care orders have been given, now the physician orders for home health care. Okay, now the physician has considered few things here, like what is the criteria, whether the patient is really requiring the home health care or not. Now that has been done. So once the physician orders home health care, now there is the doctor or the patient will come to the home, and once the patient in the home, the clinicians will come to the patient and they are going to provide the services. Now, who are the clinicians? The skilled nurses, physical therapists, occupational therapists, SLPs, and STs. Now, this is how the flow of home health care runs. Now, there is a patient who visits hospital and stabilized with the treatment. There are certain criteria to be considered, and if it's okay that this patient is required for the or met the criteria for home health care, then the physician will give the thumbs up. This patient requires home health care. Now, so there are a lot of people involved here. There is a patient, there is doctor, there is hospital, there is clinicians. Now, who are going to be, somebody going to handle all this? Maybe the referrals or the home health care orders, which doctor to take care of the patient, or who's the nurse that that are going to visit the patient. There's a lot of things involved, a lot of people involved over here, or there is a lot of process involved here. When that is the kind of thing that is happening related to the home health care, so these things will be handled by home health agency. Now, agency will decide, okay, which doctor, which nurse to take care of the patient, which nurse to visit the patient on which day, or what is the criteria, and everything will be decided by the home health agency. And our agenda is like home health agency also, we are going to discuss, how the home health agency works, what are their duties, and everything will be discussed in the next few slides. Now, we have seen how the workflow, the home health care will run, and we have also seen the definition and who are all involved. Now, these slides give you an idea that, if you see this slide, we'll have a clear-cut understanding of what is home health care is all about. Now, already we have seen, but we'll try to summarize the introduction part. What are the primary goals of the home health care? Yes, recovery from an illness, surgery, injury, or managing a chronic condition. So patient should recover from illness or surgery, or recovering from illness or surgery, they'll be getting the home health care, and that is the primary goal. Who is eligible? Patients who are homebound, certified by a doctor as being in need for intermittent skilled care and under a doctor's plan of care. Now, homebound criteria we have already discussed. That is the primary criteria that they'll be looking at, that the patient should be homebound. That means the patient is not going to be going out of the home without any support.
Srinivas, sorry to interrupt you.
Yes, ma'am.
Could you be please louder, because we see many are responding voice is not clear.
Okay. Yeah. Just a minute. Okay. So is that fine, Madhuri?
Yeah,
Now?
it is fine now. Yes,
Yeah.
it is fine now.
Thank
Thank you, Srinivas.
Thank you. So who is eligible? The eligibility is, the criteria should be homebound, and the doctor should certify the patient to get the home health care. Now, so that is what we have seen. Doctor is the person who is treating the patient in the hospital, and they are going to give the orders for home health care. Now, as being in need of intermittent skill care and under a doctor's plan of care. So these two are very, very, very important. Now we are going to see what is plan of care in the coming slides. What is intermittent skill care? That also we are going to see in the next few slides. Yes. And who provides the care? Now by this time we know the people involved are nurses, physical therapists, occupational therapists, home health aides, and medical social workers. So these are all the people involved in the care. Now who gets care? Patient. Yes, physically the patient will get the care, but the education will be given to the patient and the caregivers. So education is also very important. So every time the patient may not be eligible to get the home health care. Now once you have the education, how to handle the medication, how to handle a certain situation, then that is also very important. So education is a part of this particular care. Now who pays? There is Medicare and Medicaid along with the private insurance plans. What is covered? So it's natural that if nurse is involved, definitely there is a nursing care, physical therapy, because the PTs are involved, occupational therapy, some medical social workers, helping with bathing, dressing, and other daily tasks from home health aid also. So activities of daily living, grooming activity, maybe upper body dressing, and all these activities will be taken care sometimes if the patient is not able to do by the home health aid. Now, when it is regular visits from the home health care team with 24/7 all on-call availability. Now, one of the things that we may be able to, we should be able to understand that the nurse will visit the patient and they'll be providing the required care and they'll be moving on to next patient. So the physical presence of a clinician may not be for a very long time, maybe 1 hour, 2 hours based on the patient's condition. The nurse will be there with the patient and give the education and provide the service, and the patient will be, the nurse will be moving to the next patient. It is based on the agency's guidance. But they'll be available if there is a criticality, if there is an emergency, there is an on-call availability of 24/7. So that is what it is. So it is definitely intermittent skill care that we are going to elaborate in the next few slides. And where? Now, so we have been talking about home health care. I mean, where the patient calls home, including a private residency or a facility such as ALF, assisted living facility, or a senior living facility, etc. Now, so is it mandatory for the home health care that the patient should be in the home? That may not be the criteria. Wherever the patient stays, and if he is eligible or she is eligible, so the nurse has to visit that particular place and they should be providing the care. It can be a private residency or a facility such as ALFs, assisted living facilities. Like, if the patient is in the assisted living facility, they may call that as their own home. So they'll be paying amount of money to stay there, and they'll be getting some additional services from the building itself. So wherever the patient stays, that is their home, and the clinician should visit the patient and provide the required services. Now, how long? As long as the doctor certifies the patient is eligible for home health care. Now, this is where there is an episode, timing and everything will comes into picture. But there is no end. To technically, if I have to say that, there's no end. Like if the patient is not able to recover the kind of services that the clinicians are providing, then I think it can go on and on. So as long as the doctor certifies, the patient is eligible for home health. So that is how, if you see this slide, we should be able to understand what exactly home health care is all about. Like who's involved, what exactly is happening, who's the payer, what's covered, where it is provided, everything is mentioned in this slide. Let's move on. So why choose home health care? So as I earlier mentioned, personalized care, comfort and convenience, cost effective, improved outcomes. So personalized care goes like this. Different patients have different conditions. Maybe some patients have continuous COPD exacerbations. Yes. Or they may require oxygen, maybe continuous oxygen or intermittent oxygen. So services are tailored to the individual needs of the patient. Yes. The tailored means services are fixed in a way that that particular patient required or gets maximum care related to the particular condition that the patient is suffering with. Comfort and convenience, definitely there is everybody of us feel that, who are in the home, definitely they are comfortable and convenient. Patients receive care in the familiar and comfortable environment of their own home. So they are happy because they are in their own home and somebody is coming and providing the service. So it is win-win for both the payers and the people who are providing the service and the patients. Cost effective. Home health care is often more affordable than a hospital or nursing home. So there is a statistic that I do not want to mention, but there is a significant, difference when you compare the same service that is being provided in the hospital compared to the same service that is provided in the home. So what I'm trying to tell you, definitely there is a significant amount of variation in terms of the money that is involved in the home health care and the same service for the patient in the hospital. So definitely it's a cost effective. So there's a lot of statistics that are going around, and there are a lot of magazines which say, some 70-80% of the change, that I do not want to get into. And improved outcomes. Studies definitely show that patients who receive care at the home often recover more quickly and have better health outcomes. So that's what it is, home health care. So this is where the patient will feel comfortable and they may have recovery more quickly and better health outcomes. Now, what home health care is not. So we have seen so far that what is home health care. Now we have seen who are involved, what is the definition, what exactly the kind of services that are going to be provided for the particular patient. Now, what home health care is not. So this is where there's a common misunderstanding, I'd say, that people think that home health care is a long-term service. No, home health care is not a long-term service. When I say that, what is this long-term continuous service and what is intermittent service? Now, let me give you an idea that the patient once come back to home, clinician is definitely visiting the patient, but they are not going to be with the patient for maybe throughout the day. That is not going to happen. So there is a limited window of time, maybe 1 hour or 2 hours, based on the patient's condition. They are going to provide the service and they are going to move to the different patient. Now this is where home health agency will be taking care of. What I'm trying to tell you, that if the patient is in the need of long-term service, which is like 24/7, I think rather than being in the home, the patient must be in the hospital. A home health care is definitely not a long-term service. So to be covered by Medicare, patient needs for home health care must be a short-term or intermittent, which is not continuous, obviously. The main goals are to teach the patient how to take care for themselves, manage patient health, and live as independently as possible. Now, this is where we have to be very clear that home health care is definitely not a long-term service. So, surgical wound, the patient recently underwent a surgery. The surgical wound will be taken care. Maybe cleaning will be done and a dressing change will be done in the 1 hour, maybe 2 hours. There is some education related to antibiotic administration and prevention strategies of the complication, maybe the infection of surgical wound. So that they are going to do it, and they'll be moving to the different patients. So home health care is definitely not a long-term service, and home health care is not 24/7. Now, members of the home health team regularly visit the patient. The rest of the patient's day-to-day care will be provided by another caregiver, usually either a family member or a paid caregiver. Now, this is what it is. Even the long-term service thing that we have discussed. One more thing that will come into picture is like the critical aspects will be taken care by the nurse, and the 24/7 on-call availability will be there. And the next thing that most people should understand is that when it is not a continuous service, and there is a misunderstanding that the nurse will visit the patient on a daily basis. No, it may not be daily basis also. It may be weekly, twice or thrice, based on the patient's condition. So these two things are these are the last 2 points where this 24/7 service. Definitely there is an education involved, as I mentioned in the earlier slides, that education will make the patient stronger in terms of taking care of themselves. So that is what is home health care is not. Now, so that being discussed, so we have seen what exactly is home health care, the professionals involved, or what home health care is not, what are the key factors or the criteria involved, and everything we have seen in the last few slides. Now we are going to see, this is where our coders are really excited because this is what we do. Okay, most of the times we are coders, so we'll do the coding. Now, key components of the home health coding. Now, ICD-10 CM diagnosis coding, which is given. I mean, we should be doing it at any cost. Now, there is a specific, I'd say, area that we'll be seeing, that is OASIS, outcome and assessment information set. Now, we are going to discuss about that. POC, there is plan of care and physician documentation. So these are the three key components of home health coding. Now, ICD-10 CM diagnosis coding. So what do we use it for? So we are going to assign primary and secondary diagnosis that support the home health episode. Now, in a practical coding environment, I'd like to elaborate on primary and secondary diagnosis. Now, what is primary diagnosis? We call it as a focus of care in the case of home health care, that FOC, primary diagnosis. The primary diagnosis is reason for home health care. Why exactly the patient is in the home health care? What are the services that are being provided? That is your primary. Now, it may match to some other departments also, but what is the reason for home health care? That is what is primary is all about. Now, all the diagnosis of the comorbid conditions, acute or chronic, that have been coded on a record, they'll be considered as secondary diagnosis. So primary diagnosis has utmost importance in home health care coding. I'll mention the importance in the next slide probably. Secondary diagnosis holds the importance. I'm not saying that secondary diagnosis are not important, but the primary decides what exactly is happening with the patient, what is the kind of reimbursement that they're going to get once a particular primary diagnosis has been coded on a given record. Now, secondary diagnosis, all the comorbid conditions, including chronic and acute conditions. Now, this is where we have to be very strong with the ICD-10 CM guidelines. So when you want to become a home health care coder, yes, the ICD guidelines are given. We should know ICD guidelines, and we should know what is the criteria for selecting a primary or a secondary diagnosis. Let me elaborate, on the primary a bit. For example, as I mentioned, primary diagnosis is the reason for home health. Now, there is there's something that we need to understand, that the patient is going to hospital initially and the patient is coming back to home. Yes. Now, focus of care is why the patient is coming from hospital to home, why the physician is actually given the order for home health care. Now, there is a confusion like, why the patient is going to hospital, that is not we are going to consider for primary. Okay, there may be most of the times or majority of the times your reason for hospitalization and your reason for home health care will match. But if it is not matching, the primary diagnosis definition goes like this, that the reason for home health care is your primary. Now, this is very, very, very important in terms of the reimbursement or the care that is being given for the particular patient. This holds utmost importance. Now, the following official ICD-CM guidelines ensuring proper sequencing of primary and comorbid conditions. Now, there are a lot of sequencing guidelines related to the general ICD guidelines. The patient is suffering with diabetes and CKD, you have to sequence in a certain manner. There are assumption rules that we have. If the patient has some maybe anemia and CKD, how do we code? What is the mandatory sequencing that we are going to discuss? Now, the sequencing is absolutely important. So, I worked in HCC, I work in HCC now, but what happens is, if you're capturing the HCC risk adjusted diagnosis, probably sequencing may not be that much important. But as far as the home health care is concerned, we have to properly sequence. Now, I've seen people doing every code correctly, people capturing every code correctly and missing the sequencing. So that is where we start losing the punch. And even the clients are very much focused on sequencing of primary and comorbid conditions. Inclusion of manifestation codes. The classic example is diabetes with complications. There are a lot of assumption rules that are involved. So we have to be very careful. Coding for chronic conditions. Now, this is where I'd like to elaborate on what is chronic conditions. Of course, we are going to code if the patient has COPD, CHF, CKD, Alzheimer's disease, or maybe some Parkinson's disease. Every chronic condition will code. And one question that I generally get is, what about acute conditions? So if you have coding only chronic conditions, that becomes more or less a risk adjustment coding. Yes, because in the risk adjustment, we'll definitely see what are the chronic conditions, what are the potential conditions that we are going to see in the next year, and that is what the risk adjustment coding will be. But what is the difference when you really want to compare with the risk adjustment and home health coding? That is, we are going to capture acute conditions as well. Now, patient has acute respiratory failure. So a patient has a UTI. UTI is not a chronic condition. It's not like COPD or CHF. But we are going to capture as long as the patient is getting the treatment for that particular condition. Until it is resolved, we're going to capture. So it's a mixture of chronic and acute conditions. People may, don't get carried away that, okay, coding only chronic conditions, it virtually becomes risk adjustment coding. However, we will definitely code acute conditions based on the support that is being provided. Now, adhering to laterality and specificity requirements. Now, laterality is left, right, and specificity requirements. So there is a coding guideline that says, basic coding guideline that says you have to capture a specific diagnosis to the highest specificity that is possible, or as far as the documentation is concerned. Laterality thing, yeah, people who are experienced, they may think that, why should we miss laterality? Why would we miss laterality? Nobody misses laterality, but in the case of home health care, your laterality becomes that much more important. Lung cancer unspecified. So the provider is not able to mention or not mention whether it's a lung cancer right side or left side. Now that is your focus of care, for example. Now that is not going to be acceptable as a primary. So the system will give you or throw you a message or alert you that this is not going to be accepted as a primary, because there is no laterality specification. Now the doctor who is treating the patient should know which side the lung cancer is. So that is where your laterality becomes such an important aspect to be able to capture it as a primary diagnosis. So specificity is, you have diabetic polyneuropathy and diabetic neuropathy. Definitely we'll go to polyneuropathy. So these are the basic ICDs that we are going to adhere to. And home health documentation requirements. Now let me give you a very simplistic idea. I may not go deep dive, but if you see a documentation of risk adjustment, maybe some 10 pages, 100 pages, 1000 pages, but it's a single document. It's a single document. As far as the home health care documentation is concerned, you have multiple documents to correlate from. So I don't want to mention the specific names, but there are multiple documents that you need to correlate to each other before you come to a primary diagnosis coding or a secondary diagnosis coding. So that is where it becomes much more interesting. It is not a tough job to do, but it is a complex. You need to do a lot of correlation before you give a primary or a secondary diagnosis. So official 10CM guidelines are absolutely the top priority, and proper sequencing, manifestation codes, coding of chronic and acute conditions of codes. The laterality part becomes very important, because if you are coding an unspecified code, that becomes not acceptable as a primary. Now, what is this OASIS? Now I'll give you a brief idea of the OASIS, and before I start with the OASIS, on the right hand side, if you can see that, let us elaborate. OASIS is outcome and assessment information set. Now there are a lot of versions of OASIS. Like, it started in 1999 as OASIS, then it becomes OASIS B in 2002, OASIS B1 in 2008, OASIS C in 2010, 2014 become C1, 2017 it becomes C2, and 2019 D, 2020 D1, and it is OASIS E from 2023. Now we are in OASIS E1 from 2025. Now there are a lot of transition, or I would say the versions that have been available for the OASIS. So now the first and important statement that I'd like to make here is that OASIS is not a coding. Now people may think that what is this is all about. OASIS is definitely not a coding, but coding will influence your OASIS. Coding will influence your OASIS markings and all, but it is not a coding. It's not a direct coding. Now, if you see who knows OASIS, only the home health coder knows OASIS. Nobody else will know what exactly OASIS is all about, to be very clear. Now, so I just want to, give you an idea how the OASIS works. OASIS is a form which will have items based on the different body systems or based on administration, like administrative items like what is the patient name, gender, date of birth. So when you see a form of OASIS is simply a form with multiple M items, B items, C items and all. When you see this form, which is filled by clinician, you have every information about the patient. I would say, patient's name, DOB, it starts like that, and what is the race, ethnicity, whether the patient is able to walk, whether the patient is wheelchair bound, what are the different conditions that the patient is suffering from, whether the patient is able to groom himself or herself. It is like, a document which gives you a lot of information about the patient, a lot of information, which is being filled by the clinician. Now, it is used for Medicare patient assessment and payment classification. So how does the OASIS impacts the payment? That we are going to discuss in the next slide. Coders must ensure alignment of the ICD-10 CM codes with OASIS functional score. So what I'm trying to tell you, there are different areas even in the OASIS. So I mentioned like administrative, then related to hearing, there is a separate section. Related to the functional ability, there is a separate section and all. So what I'm trying to tell you, as I told you in the last few minutes, that OASIS is definitely not a coding, but your coding influences OASIS, maybe the functional scores, maybe the, whether the patient is suffering with a diabetes and all. So I don't want to really get into the item-wise discussion, but OASIS is not coding. Again, I'm telling you, most people ask this question, but your coding will definitely impact the OASIS. So, by looking at the OASIS form, you can say patient has a surgical wound, yes or no. Patient is suffering with some pressure ulcer, yes or no. If the pressure ulcer is there, what is the stage? Maybe stage 1, 2, 3, 4. What is the most problematic pressure ulcer that the patient is suffering with? If the patient has any stasis ulcer, or if the patient is able to walk on uneven surface, even surface. So there is a lot of detailing that is given in the OASIS that has been marked by clinician. So now the next question that comes to your mind is like, okay, if the clinician is already marking, so what is our duty to do with the OASIS? Or what do we have to do? Right? Coding, you're seeing the documentation, you're correlating, you're identifying primary and secondary, that is absolutely okay. But what do we do with the OASIS? Right? I mean, which is, technically or already marked by the clinician. So this is where we becomes that much more important as a home health coder, that you will double check what exactly is marked by the clinician. Now, clinician may not always be correct. So what you do is based on the documentation that you read for coding. So you will be applying that documentation on the OASIS also. If you really have to suggest a change as far as the OASIS markings by the clinician is concerned, you can do it. You are allowed to do it. Okay. For example, let me give you a very simple example. The patient is, the clinician has marked that as far as the grooming activity is concerned, the patient is independent, but you feel or you seen a documentation where the patient is not having a strength in the hands. Now, the patient may not be able to independently perform this activity. So this is where you have to be very careful that the clinician marks it. Yes, clinician is the person who is physically seeing the patient. Even though if your documentation supports, you're going to make a change in the OASIS form based on the documentation that has been provided to you. Now, there are a lot of versions, but now we are in 2025 year and we are using OASIS E1. Now, the manual will be open source document that we can get from CMS website, and you can check it over yourself. Now, the The other thing that we need to be looking at is plan of care and physician documentation. Yes, physician documentation is very important. Now we have seen, we have been discussing about home health coding, what is happening in the home. But a coder who is working as home health, working in the department of the home health, is also responsible for all the hospital documentations, like maybe physician order, therapy notes, and nursing assessment, HNPs, progress notes. So it goes to all the eligibility or all the documents which are valid. Sorry, you can check all the documents and you can capture the diagnosis from the documents. Now, POC, I want to elaborate on the POC. POC is nothing but plan of care, and it is also called as 485. The form, it is a 485 form. Now, what does the POC contains? What are the POC? POC is a detailed document that the clinician will be following. You know, this has been approved by the doctor and the agency. So they'll be you know, listing all the services that they're going to provide to the patient as far as the particular patient services are concerned. So when you see the POC, so you'll get an idea that, okay, the patient is going to get XYZ services during this particular episode. So that is, POC is a simple document which lists all the services that they're going to provide to the patient during that particular time period. Now, ensure MEAT, that meet concept, that monitoring, evaluating, assessing, and treating criteria. But yes, when you're coding a condition, there should be one of the components, like you know, they have to monitor or evaluate or assess or treat. So we have to have that criteria met when you want to get into the, when you want to capture a diagnosis which is probably as a primary or a secondary. Now, these are the key components of the home health care. Now, ICD-10 CM diagnosis coding is given. We have to know sequencing is absolutely mandatory. Manifestations, chronic and acute conditions, laterality, specificity requirements. And OASIS, have given you idea about the OASIS, and I'd like to repeat this thing that OASIS is not coding, but OASIS is definitely being influenced by the coding. So POC is a document that says what exactly they're going to do with the patient. Now, physician documentation is like HNP, physician orders, therapy notes, and nursing assessments. Ensure meet, monitoring, evaluating, assessing, and treating. These criteria should be met. Now, okay, we have seen home health care. What are the key components? But you have coded a record. But how does the payment works? What is the payment model that they're going to use? The payment model is PDGM, that is patient-driven groupings model. What is this is all about? Let me give you an idea. So PDGM is, okay, there was an older system, like PDGM replaced the old PPS model in 2020, shifting focus from therapy-driven reimbursement to clinical characteristics and patient needs. Now, so we know OBPS and IPPS, just like that. There was a PPS, that is prospective payment system. In this, what they used to do is, like, you know, in this PPS model, the reimbursement was purely driven by therapy. Now, what I mean by that is how many times in a week or in a day that the nurse is visiting the patient. So that was the key factor that was going to decide the reimbursement in that particular model. So the PPS model was how many times the nurse is visiting the patient, how many types of therapy or physical therapy is visiting the patient. So reimbursement was purely driven by the number of visits that the nurse is making or a therapist is making to the patient. Now that is being replaced by PDGM, that is patient-driven groupings model. Now, what does that patient-driven groupings model is all about? Let's understand that also. But patient-driven groupings model has replaced this therapy-driven reimbursement with clinical characteristics and patient needs. So what is this clinical characteristics? What exactly is happening with the patient? They're not looking at how many times the patient is being visited by nurse or a physical therapist, but how much of the patient's impact or patient is impacting because of XYZ, maybe the diagnosis or, you know, the needs. Now, what are the key features and what is the impact on the coders? Before we discuss this, home health PDGM model is depending on 4 factors. The first factor is admission source. The admission source is like from where the patient is coming and joining the hospital or home health. Now, this is where we don't have any control, or we don't do anything with that. They'll be deciding by that will be decided by the agency. Now, the next most important thing is primary diagnosis. So the next most important thing is like clinical grouping. So what are these clinical groupings? If you would see, if I have to compare this with some other department, if you see CMS, HCC, there are, you know, psychiatric related, there are infection related. Like that, we have 12 clinical groupings in the PDGM model. Now, it goes like it starts with wound, musculoskeletal rehabilitation, aftercare, neurology, cardiac, etc. Now, the clinical groupings are purely based on the primary diagnosis that you are coding. Now, how does these two relates to each other? For example, if you are coding a diabetes, you are placing the patient in the endocrine clinical grouping. If you are coding a surgical wound infection, you are placing the patient in the wound clinical grouping. Now, there is a rating by which the reimbursement will be decided. So that is the reason I was talking about the importance of the primary diagnosis. Excuse me. So what is this clinical grouping is all about? That there are 12 clinical groupings, and whatever the primary that you are assigning or capturing from the documentation, that will follow in any of the clinical groupings, and that will in turn decide the reimbursement for that particular patient. So clinical grouping is very important, and that will depend on your primary, and the primary diagnosis is absolutely important because your reimbursement will be, you know, impacted highly because of the wrong primary diagnosis. If you are giving a primary diagnosis as diabetes, and you know the clinician or the physician says the the primary diagnosis is wound, then there is a lot of difference in the payment. Now that is where your agency will be affected badly. The, you know, of course there is a finances involved, but along with that there is also patient care that is involved. We have to be clear, right? If instead of wound, if you are coding a diabetes, that's not going to help the patient in any way. So clinical grouping will be decided by the primary diagnosis that is been coded by a medical coder. Now you may have a doubt. So we have so many codes, thousands of codes. So every code will be falling into any of these clinical groupings? Definitely not. Now, for example, if the patient is having headache, that is not even a clinical, that is not even acceptable as primary. So there are codes which are acceptable as a primary, and there are codes which are not acceptable as a primary. So we should be very careful with the clinical groupings. In turn, depend on the primary diagnosis. So I've given example in the last few minutes that if the patient is suffering with a lung cancer and there is no laterality specific when will accept cancer. So that means there should be a laterality, then only the system will accept as a primary diagnosis, and that will fall into any of the clinical grouping. So all the diagnoses are not going to be acceptable as a primary and not going to be grouped in the clinical groupings. And the next thing is, okay, we have seen primary diagnosis, clinical grouping, reimbursement effect, impact. So what about the secondary diagnosis? In a given chart, you are coding around 30 to 40 codes, for example. Now, okay, your primary is utmost important. That's what we have discussed so far. Then what about the secondary diagnosis? What is the impact of secondary diagnosis on the overall payment model? Secondary diagnoses are also important. So based on the certain combinations of codes you give in the secondary diagnosis, we call it as comorbidity adjustment. So that will fall into low, high, or none based on the secondary diagnosis. So secondary conditions. You've coded, for example, let's take a simple number of 10 codes. You have coded 10 codes. Your primary diagnosis decides the clinical grouping, and your second code to the last code will decide the comorbidity adjustments, there are three categories like low, high, or none. Now, what is the impact on the coder? So, okay, you have coded a record. So the two things that are very important is like you must select appropriate primary diagnosis that map to a PDGM group. Now, this is one of the challenging part, because sometimes you may not be able to really understand what is the focus for which the patient is in the home health care. But this becomes utmost important because you are giving a code which is acceptable but not as the appropriate PDGM group, that is also impact the reimbursement. And sometimes you are giving a code which is not acceptable in the PDGM, which is absolutely, pretty much a critical aspect of this particular coding, because you code a primary which should be acceptable in the PDGM group, right? Then ensure accurate comorbidity adjustment for appropriate reimbursement. So, so we have been discussing like primary diagnosis, like everything, but your primary diagnosis should be supported in a PDGM group, and your secondary diagnosis are also most important for comorbidity adjustments. Now, this makes a home health payment model that is PDGM. So there are definitely what is the admission source, and you're considering a clinical grouping based on the primary diagnosis. You're considering a comorbidity adjustment based on the secondary diagnosis. There is one more part. We are marking OASIS. So based on the different items that you mark on the OASIS, patient's functional impairment level also will be decided. So now the next question most of the people may have in their minds is like, okay, am I going to decide this payment directly? No, you're not going to do anything with the payment, but our duty is to give the correct primary diagnosis and correct secondary diagnosis and mark the OASIS appropriately based on the documentation. When you do this, the entire cycle will be very smooth, because primary is fixed, secondary diagnosis are correct, you followed everything related to laterality, specificity, or sequencing, everything is clear. You have coded the medications related codes, you have also coded history related codes. There are a lot of things that have been taken care, and everything is okay. You have marked the OASIS correctly, then this payment model will work smoothly. Now, again, I'd like to reiterate on the primary diagnosis. That is where most of the problems will arise. So we have to be very clear with the primary diagnosis. So that is your payment model. And the next thing is home health agency. So initially we have discussed like home health agency, what exactly it is. They are going to handle all the clinicians and the doctors, when the referral should be made, when the order should be given. Everything will be taken care of. And HHA is a public or private organization that delivers skilled nursing and other therapeutic services to a patient's personal residence rather than in a more traditional healthcare facility setting. So that's what we have discussed. Like home health agency will decide which nurse to go, which that 1 service or a 2-hour service, what they should do, what are the services that they should be providing in the home. These are all the areas that they're going to focus on. A home health agency provides healthcare services in a patient's home. Yes, that's what we have seen. These services are typically offered to individuals who are recovering from surgery, managing chronic conditions, or need assistance with daily activities. And home health services can include nursing care, therapy, personal care services, and home health agencies ensure patients receive quality care without needing to be in a hospital or nursing facility. Now that is what is home health care is all about. Home health agency is all about. Now you have a patient in the home, and if you provide a quality care, so next now the patient is falling, there is an injury, the patient should go to hospital. Now that is where your clinicians will come into picture, and they will give you a care, or maybe a physical therapist will work with the strengthening of your extremities. Now they will prevent the falling. If you fall, there may be an injury, again there is a hospitalization. So the prevention of hospitalization along with the education related to the specific diagnosis that the patient is suffering with, or surgery related things, everything will be taken care by the home health agency. Now home health agency will also, we have seen services offered by home health agencies like skilled nursing care, physical therapy, occupational therapy, speech therapy, and personal care assistance. So medical care by registered nurses, including wound care, administering medications, and monitoring vital signs. That is the duty of skilled nurse. Physical therapy, helping the patients regain strength, mobility, or independence after a surgery or an injury. So maybe a stroke patient has hemiparesis, and the physical therapy might be the appropriate service that they should be getting. Now, occupational therapies, again, like bathing, dressing, and upper extremity related strengthening will happen, will be provided by the occupational therapy. Now, speech therapy, treatment for the patient with speech or swallowing difficulties. Like the patient is not able to swallow, there is a dysarthria, the speech therapy will come into picture, and help with non-medical activities like bathing, grooming, and housekeeping. So these are the services offered by home health agencies. Now, home health agency is, because the home health care is pretty much critical for the people who are requiring services. Home health agency will also take care of the referrals, home health care orders, and they should adhere to the national and the state policies of the care, because you have home health agency, and how do they get the money? What are they going to do? So they are going to service. They are the service providers for different patients in different places. But how they are going to be, maybe evaluated, the kind of service that the home health agency is providing. Now they have the star ratings. Actually, they have the star ratings, and a person from federal government will visit the home health agency, and they'll be taking the surveys. They'll be reviewing the documentation, and if everything is good, they are going to get the payment. So now your coding is also impacting, because if you give a wrong primary diagnosis, that will affect your agency's finances also. So that is where there are a lot of people involved in the agency for the referrals, for the regulatory things that they have to follow. Now, levels of home health coding. So now, if you're working in different departments, maybe based on the body system, you may be getting the charts. But in the home health coding, there are different levels. So as a fresher, when we start with coding only. Then we'll go to coding and OASIS review. So let us discuss about this. In the next few slides, we are going to have a detailed discussion about the different levels. So the levels goes as follows: like level 1, coding only home health. Level 2 is coding and OASIS review. Level 3 is coding, OASIS review, and plan of care review. Discharge, OASIS review. Now, let us see what are these levels are all about. Level 1, coding only home health. So on these kind of charts, or these charts are being given to you, what do you do? So you only code the record. It's very simple that you only code the record. So that is the reason why we are calling it as coding only. So this review process allows for efficient coding with minimal documentation assessment, suitable for situations where a comprehensive OASIS data review is unnecessary. It still ensures accuracy and compliance for home health records. Now, so how do I decide as a coder? So how do I decide that I have a OASIS review or a coding only review? They'll be clearly stating that this particular record should be worked for only coding. Now, what do? What is the scope of your work for this particular type of charts? The scope of review is very simple, that you are going to select correct physician verified diagnosis, application of correct ICD codes and sequencing, suggestion of severity ratings when applicable to the client process. Now you are just coding primary diagnosis and a secondary diagnosis. You're not looking at the OASIS, in this level of review. Now you see suggestion of severity ratings when applicable to client process is that there are different severity ratings. You have coded 20 diagnoses. So based on the diagnosis that you are coding, or the severity of that particular condition, if there is a patient who is having COPD exacerbation. Now the clinical or the severity ratings will be out of 1, 2, 3, 4. You have to select 2 or 3. Now that will be decided by your agency or the client. Now severity ratings will start from 1, 2, 3, 4. Now generally we'll go with 2, and if the condition is exacerbated or critical to manage, then it can be like 3 or 4. Now that also we are going to apply for each diagnosis from primary to the last diagnosis. So in the level 1 coding, we only do the coding on a given home health care record. We don't do anything related to OASIS, and the scope is very simple. We are going to code the primary diagnosis and the secondary diagnosis, and we are going to apply the severity ratings when applicable for the client process. If the client is asking us to give a severity rating, then definitely we need to pick up the severity rating for the condition based on the level of severity that the condition is having. Now the next one is level 2, coding and OASIS review. Coding and OASIS review. This review process enables efficient coding along with additional documentation review, especially when a full OASIS data review is not required. Okay. It ensures accuracy and compliance with the home health records, even in the cases where a comprehensive review is not fully conducted. So again, as I mentioned, OASIS is having multiple M items. So level 2, you're doing coding and also OASIS, but your OASIS review is limited, I'd say, because the patient might not be requiring all the data to be reviewed. It is up to the agency to decide which level of coding that you need to do it, or which level of OASIS that you need to do on a given record. So level 2 is like coding and OASIS review. Now you may be having a different terminology that they may use, like level 2. Some people use 2.53, and some people use like OASIS core and advanced. So it is up to them to decide. But what are the different OASIS items that you are going to review? It is purely based on the type of chart that you are working on, which the agency will give you an understanding. Now, this is a general understanding. Level 2 will be coding the record, and you're also having the OASIS review, but the items are limited. Now, coding scope, obviously selection of correct physician verified diagnosis, application of correct ICD codes and sequencing, suggestion of severity ratings when applicable to client process. Obviously, coding, as we discussed in the level 1, the coding will be goes as same. Now, coding scope, OASIS review of all OASIS data in assigned OASIS time point. So now, sir, which OASIS item I need to work on? So that is purely based on the type of chart that you are working, or type of which agency you are working, and they are going to decide what are the OASIS items that you're going to work. That is level 2. Level 3, there's a coding, there's a OASIS review and plan of care review. Now, already we have seen coding and OASIS review. What is this plan of care review? That we are going to discuss in the next few slides. Now, this review process involves an in-depth and detailed review of the patient's home health care plan. This level focuses on comprehensive documentation, coding, and thorough assessment of all relevant clinical aspects, making it ideal for patients with more complex or high acuity conditions requiring extensive care and intervention. So this is where you are going to mark. Of course, you are going to code the record. You are going to mark all the OASIS items. This is specifically for the patients with more complex or high acuity conditions requiring extensive care and intervention. So the plan of care review is an additional thing that we are going to see here. Level 3 coding represents the most thorough review in home health coding, ensuring complete and accurate documentation, proper coding, and compliance with the regulatory standards. So given you have to follow the regulatory standards at any cost, and you will, when you are working on a level 3 chart, so you are going to do almost everything with the home health coding. So you are going to code the record, you are going to mark the OASIS items, and you are going to do the POC review. Now let us see what is POC review in the next slide. Now, coding scope goes like this: selection of correct physician verified diagnosis, application of correct ICD-10 codes and sequencing, suggestion of severity ratings when applicable to the client process. So coding scope is definitely there. That's, we have to give the primary diagnosis and secondary diagnosis, and we have to apply the severity ratings for different conditions based on the severity. Now, OASIS review of all OASIS data in assigned OASIS time points. So we are going to mark every OASIS item that is possible and that has been indicated by the client. Now, what is this POC review? Plan of care, as we have earlier seen, that's plan of care in the home health coding is a crucial component of the documentation that outlines the specific course of treatment and services that will be provided to a patient in their home. Now, okay, plan of care is a simple document, as I mentioned earlier. This is a very crucial component because it will outline the type of services that they are going to provide in the home health or home, and that will be provided to the patient in the home. Yes, it is developed by healthcare providers such as a registered nurse, physician, and therapist, and is used to guide the delivery of services and ensure that the patient needs are met. So when you have a plan of care documentation or document in your hand, you literally know that what is happening with the patient, that what exactly the kind of services that they're going to provide, what are the goals, or what are the recommendations that they have, and all these things will be mentioned in the POC document. Now, coding scope, plan of care review, that you are going to review POC items with correct correlation with both the coding and OASIS items in assigned OASIS time points. Now, I just want to give you one or two examples. So the patient is using a medication. So there are 4 components related to medication, like severity, the frequency, the dose, the medication, and the type of route of administration. So if patient has missed something, so they missed the dose, then you are going to suggest that, okay, this particular patient is taking this particular medication, but there is a missing of dose. So please do the change, or we are going to suggest to the clinician. So there is a diet, for example, the patient is diabetic, but there is no, a diabetic diet that is mentioned on the POC. So you're going to suggest to the clinician that, okay, this is what is the patient is suffering with, and I could not see the, recommendation or a diet that the patient should be taking. So, there are some locators. We would call them locators. That's each locator has a specific scope, and we are going to suggest to the clinician that, okay, this is what it is missing. Could you please change? So there are a lot of templates involved, a lot of query templates, a lot of suggestion templates that are involved. So that we are going to do during our POC review. So now let me talk about the next one is discharge OASIS review. The discharge OASIS is like review is a key part of the home health care process. So OASIS is a standard tool used by Medicare certified home health agencies to assess the clinician status, functional abilities, and care needs of patients. It is used at several points during the care process, including at admission, recertification, and discharge. Now, the discharge OASIS specifically takes place when the patient is discharged from home health care, whether it's because the patient has met their goals or is no longer eligible for services or has chosen to discontinue care. So discharge is simply the home health care is stopped for variety of reasons. Sometimes the patient can be like, the goals are met, or sometimes the eligibility criteria might change, or the patient has really chosen to discontinue care. I don't want any more home health care. So that may be the reason. So discharge OASIS review is also one of the key aspects. And coding scope, discharge review of all OASIS data to determine if a patient's condition had an improvement or a decline from SOC to discharge or ROC to discharge. Now, how does the agency benefits from a proper OASIS marking and coding? Now, for patient, let's take one example. If a patient was not able to walk before the patient has been initiated with the home health care, the patient was literally not able to walk. Now, after the episode of 60 days, the patient is walking, maybe by using a cane or a stand or something like that. Now, that is an improvement that the agency people are showing. So there should be a positive improvement in the patient's condition, be it ambulation, be it grooming, be it any medical condition, maybe a surgical wound, care. So there should be a positive change that should happen to the patient as far as the medical conditions or the functional abilities or the status of the patient. So that is the case, and if there is a positive change that is happening, then the agency will get the positive outcomes. They'll get the star ratings as I mentioned earlier. So these are the different levels of home health coding: level 1, 2, 3, and discharge OASIS review. As I mentioned, this is the a broad understanding of how the home health coding works. Coding part, then you will do OASIS review, then you will do coding OASIS and plan of care review, and you will also do discharge OASIS review, sometimes based on the agency's allocation. Now, I think we are almost at the end. That is, what are the challenges in home health coding? Now, there are a lot of challenges, but thing that we need to be very, very clear, or we have selected two of the challenges. That is selecting the correct primary diagnosis under PDGM. So under the patient-driven groupings model, accurately selecting the correct primary diagnosis is essential for proper reimbursement and compliance. Incorrect diagnosis codes can result in claim denials, delays, or audits. So as we are clear, like if you're not capturing a diagnosis, which is the primary diagnosis that has been indicated by both the doctor and the clinician, you have given a completely different diagnosis, that is going to have a lot of problems the back end. Now, reimbursement will be impacted, obviously. claim can be denied. There may be a delay. There may be, audit delay because you have completely given a wrong diagnosis. On top of it, selecting a different PDGM code, the coders will sometimes select a non-PDGM code, which is not even acceptable as a primary. Now, okay, you have selected a different PDGM code. To some extent, they may think that okay, there is a difference in understanding of the record. But if you are giving a primary diagnosis which is not even acceptable in the PDGM, is going to create a lot of problems. So the impact will be incorrect coding can negatively affect the patient care, reimbursement rates, and as I mentioned, agency finances. Now, you're coding diabetes as a primary, but the original focus of care is your wound care. Now, there is a reimbursement problem, there is an agency financial issue. Back, you are wrong processes that are happening around it. Now, second challenge is ensuring documentation supports risk-adjusted HCC coding. So you may think that, what is this risk-adjusted HCC coding? So even though we are working on a home health coding, the diagnosis that we are starting giving in the start, like top 6 diagnosis, nowadays there's a guidance that we should give all the top 6 diagnoses which are from HCC category. Home health agencies must ensure that documentation supports HCC, that is hierarchical condition category coding. These codes are used to calculate risk adjustment for patient outcomes, affecting reimbursement rates. Incomplete or inadequate documentation may lead to improper risk adjustment. So if an agency gives you a document which has incomplete information, so coder will work on it, and maybe sometimes the query process is involved if you have incomplete information. But if the agency gives you a proper documentation, then it is our duty to select the proper risk adjustment codes and sequence them in the order to get the appropriate reimbursement for that particular patient, and it will impact the patient outcomes and reimbursement rates if you are not able to sequence them in the proper direction or proper way. Now, impact is lack of proper documentation can lead to financial penalties and missed opportunities for reimbursement. Okay, now we are seeing on the coder's end. Now, what about your documentation itself gives you a wrong, idea that okay, there is a diabetes, but focus of care is diabetes, but you are in all the areas when you check it, you are feeling like the focus of care is wound care. Now, you would go ahead and maybe code, but when you code it, you're not the one to get the blame because the documentation is given in such a way. But whenever there is a conflicting information as far as the home health documentation is concerned, it is the coder's duty to query and double check whether the primary diagnosis is XYZ or not. Now, that is also very important aspect of the home health care coding. So we have to query to better understand what is actually happening with the patient. So they may say wound care, you may feel diabetes, or you may feel hypertension, which is going to impact the patient care, reimbursement of the overall reimbursement of the particular patient, and financial penalties are definitely attached to it. So the documentation is utmost important, and when you have a clear-cut documentation, it is coder's duty to clearly understand and interpret the primary diagnosis and all the secondary diagnosis and sequencing top 6 diagnoses as HCCs. So these are the 2 challenges that we generally see. Now, what are the solutions? We have seen 2 challenges: selection of the primary diagnosis correctly, and documentation supports risk-adjusted HCC coding. Now, what are the solutions? Solutions to overcome coding challenges, like you have AI-driven coding tools to flag invalid diagnosis. So the first problem was to have the correct primary diagnosis. Now, when you have AI assistance, within the coding EMR, that you implementing AI-powered tools can help flag potentially invalid or inaccurate primary diagnosis in real time. These tools analyze patient data and provide suggestions based on the coding guidelines, ensuring that the correct diagnosis is selected. Okay, that will that may eliminate the problem maybe 80% of the times or 90% of the times. Your AI suggestions may eliminate the problem. Okay. Benefit is like reduces human error and ensures more accurate coding, improving the overall reimbursement process. Now, yes, you have already a suggestion. You're there to just double check whether the suggestion is correct or not. But one of the most common problem that I have seen, that you can prevent it manually. So you don't have to use AI. You have a manual prevention. Like, it is also the responsibility of the user to ensure the accurate primary diagnosis, which will map to one of the PDGM category and indicates the care that is being provided in the home health care. Now, what I'm trying to tell you is that, as a coder, you may not rely every time on the AI. AI will give suggestions. AI is not, like you're not going to get every code out of the AI. Now, what happens with regards to the primary diagnosis is that when the coder is given a unacceptable PDGM code in the first place, the system will alert you. That is there already, that is implemented in almost all of the platforms. Now, even after system alerted you that you cannot give this as a primary, it is then becomes utmost important for the coder to decide whether they are going ahead or whether they are not able to understand, whether there is a query opportunity, whether they have to be very careful with the documentation. This is up to the coder to decide, because the manual prevention is pretty much required because you already have alert from the system. Now, even after alerting, and if you are going ahead and submitting the record with the unacceptable primary, then that is going to be a lot of problem for everybody, the organization's point of view, or for the client point of view, or for the agency point of view, reimbursement, and the care that has been provided with a particular patient. Now, I'd use one term, that is hard stop and soft stop. So, system will soft stop you, that system will only alert you. It will not, like, system will not, give you a hard stop that, okay, this is not an acceptable code, so I won't allow you to submit the record. You can still submit the record. Now, that is what, the system will not do. Hard stop will not be done by the system. You can still submit the record even with unacceptable PDGM code. Now, that is where your manual prevention becomes that much more important. So we have to be very careful. I think primary diagnosis is one of the important aspect in the home health care coding that will decide the reimbursement, patient care, everything will, revolve around this particular primary diagnosis. So you cannot solely depend on the AI. Yes, AI will assist us, suggest us, but still the manual prevention is the best way to do it. And there is no hard stop as far as I know. You can still submit the record with the unacceptable PDGM code, which should be definitely avoided by the coders. Now, the second challenge that we have seen is like, documentation related thing, and there should be a meet compliance reviews before submission. So details are like, MEET stands for monitoring, evaluation, and assessment and treatment. These compliance reviews ensure that all documentation is complete and supports the HCC coding, guaranteeing proper risk adjustment. Regular reviews help identify gaps in documentation before claims are submitted to the payer. So this is where, if you're missing a condition, if there is a documentation, lock of documentation, so what you have to do is definitely we can query the responsible party, and they're going to provide the required documentation. So insufficient documentation, you cannot just simply submit the record, and you should also follow the MEET concept, whether the condition is monitored or evaluated or assessed or treated. A benefit is like enhances documentation quality, ensuring that the risk adjusted HCC codes are accurate and compliant with the regulations. So this is where we have to be very, clever in a way that if you do not have a, sufficient documentation, you don't have to hesitate. Under the given templates, you can query for specific documentation or specific laterality. The query process holds very much important, aspect of this particular home health coding, because when you query, you will get a proper answer, and you are going to, properly give the coding part, and the OASIS and everything will be done. So that is the end of this session. It's not session, but end of the slides. Thank you so much for your time. Now it's the time for questions.
Yeah, thank you, Srinivas. Thank you for very well explanation. We received a few questions during the presentation. I'll walk you through the questions. You can respond, Srinivas. Okay. Srinivas, am I audible?
Yes, you're audible. Please go ahead, please.
Okay. See, the question is related to, is chemotherapy patient can be given home health care?
Chemotherapy patient can be given home health care. Can you hear me?
Yeah, I can hear you.
Okay. So, if the patient is undergoing chemotherapy, there is one thing that they should be able to understand, that chemotherapy cannot be provided in the home. That is for sure. There is no question on that. But the next thing that we can understand is the patient is going for a chemotherapy treatment and the patient is currently suffering with the cancer. They can be ordered with the home health care and they can get the treatment in the home. But the patient cannot admit to the hospital while the home health care is happening. So they are absolutely eligible to get the home health care even if the patient is suffering with the cancer and getting the chemotherapy. The problem with this is that where exactly is chemotherapy is happening? Chemotherapy is definitely given in the hospital. So if the patient is going to hospital during the home health care, that is also allowed. But there are different levels of understanding that they need to have. Patients who are taking chemotherapy as an outpatient, they're definitely eligible to get the home health care. Yes.
Got you. I hope this answers the question. The second question is related to AWV visits. So, can AWV visit perform in home health?
Annual wellness, generally annual wellness, I have not seen the annual wellness visits that have been given in the home healthcare records. So what happens is, like, the patient goes to hospital for a specific condition, the patient comes back to home. So I think the documentation itself will not be coming to you as far as the AW, that is annual wellness visit. I don't see that kind of a record coming to you. But if that is coming, still you are going to take the chronic conditions from that particular record, and there is a certain time frame, Madhuri, based on the number of days that you are allowed to take a documentation from. So if your documentation is within some 60 days, 90 days, there are certain time frames that we need to look at it. And if the documentation is valid, we are not looking at the type of visit that it is. So if the documentation is valid and it is within the time frame, we are absolutely okay to go ahead and take the diagnosis from that particular record.
Yeah, so it is mostly depends on the documentation, right?
Yes,
so
yes.
we cannot give a general answer to this. We have to check the documentation. Then if it is eligible for the criteria, then you can quote the diagnosis from AWV.
But the thing is, like, AWV, we may not be able to see in the records, but as per the time frame, if it is there, we can do it. Yes, you are right. Yeah.
Okay, got you. And there is another question that is related to physicians. All physicians authorized to write that the patient is eligible for home health care?
I think the credential concept goes just like any other department. So maybe a MD or a PA, NP, so they are eligible. The unacceptable physicians are, as we know, right? So the credential concept will not change. That will be there. So RN cannot basically order a home health care. No. So there should be a doctor, and he should have a a valid credential to allow the home health care or order the home health care. So that is not different from. I believe that is not different from any other departments, Madhuri.
Yeah, so for all specialties, whenever we code, that is our responsibility to verify the physician's signature and verify the physician's credentials. If the physician is eligible to perform the service, whether that is related to home health care or any other department, then yes, obviously you can go ahead and bill that physicians.
Yes, you're correct.
Yeah. So there is another question. Does home health coding deals only with the ICD?
Let me answer this first.
Yes,
generally, home health is all about ICD and the OASIS codes. There are some hospitals or some agencies where they bill for physician services separately. They have some E&M level, But however, it is all about mastering ICD codes, ICD guidelines, how sequencing chronic conditions, and how are we reporting the OASIS.
So, Adi, thank you for the response. Few people, they are not clear with the OASIS. They are requesting the what proper guidance for OASIS, Adi.
Okay, so OASIS is not a simple concept where we can teach in hours, Madhuri. So let me give elaborative part here. If someone now in the home health, there are two certifications that comes up. One, the BCHHC, that is like someone is eligible to code until level 2 of the home health coding. For OASIS, there is another set of training session that happens. Someone has to master, and there is another certification for OASIS as well. Okay, and so in order to get these certifications, there is a complete course that someone has to complete them. So there are some clients who says, okay, we are okay with BCHHC, but we need the OASIS coding as well by the coder. There's they go through an additional level of training. When Srini is talking about different levels of home health coding, don't misunderstand it as like an E&M levels. Okay, though it talks about level 1, level 2, 2.5, it is the extension of the services. Similarly, when the OASIS comes in, it's a separate set of codes that someone has to learn along with the diagnosis codes.
Okay. So, is there any certification available for home health coders?
Yes, there is a home health certification. So if anyone needs those certification or any career guidance details, they can directly message me or Srini. Srini is a BCHHC certified and is been working for home health for more than a decade now. And reach out to both of us in person. We can definitely provide, because right now in the market, in the industry, there are no academies who provide the home health certification training. There's only one academy that does. If anyone wants to know the details, reach out to Srini or me. We can help you on.
Okay, thank you. Thank you so much for in detailed response, Adi. There are few more questions related to home health, which are which documents the coders require to conclude for the primary diagnosis?
Yes, it's important. The most important aspect in home health coding is the primary diagnosis and the additional diagnosis, and chronic conditions and the sequencing. If someone is master in picking up these codes, they can definitely work on home health. Srini, do you want to add anything there?
I think my answer is on the similar lines, that if you're really, really comfortable with ICD coding, you can master it. And I'll also add related to the OASIS, ma'am, that you already elaborately discussed. But one thing is, it is not going to be a one-shot kind of thing. It takes a huge amount of practice that should go in.
Correct.
Companies are looking at the people with maybe the coding only experience. Then they'll be taking the people into OASIS. So it goes like that you need to be very much clear with the ICD, and then you are going to master it. And OASIS is a part of home health coding. And if you are mastering ICD, I think it will not be a problem for you to go ahead and do the OASIS. Yes, thank you.
Absolutely.
Thank you, Srini. The other question is related to the conditions. Can you give examples of conditions that a patient is eligible for home health care, apart from fractures, CVA, paralysis?
I think it goes like this, that I don't want to mention any other departments, but there are some departments where they'll only fracture on some of the chapters in ICD. But if you're working in home health, definitely you're going to, I think, accept the external causes coding. Remaining all the chapters you will be seeing on a daily basis. So it starts with infections, it goes with cancers, then diabetes is one of the most important chapter. Then maybe a substance dependence, abuse of a substance. Then there is a depression related thing, psychiatric conditions, bipolar, obsessive compulsive disorder.
So it's, I think, Srini, sorry to stop you. I think it's a tough time to say that, what are those conditions which require home health? Because out of 75,000 diagnosis scores, how many conditions can we infer? So any condition which requires a long-term care and which requires an acute care, which requires very intensive care, they might come into the home health. And whoever comes into these agencies for taking up the care, all those conditions are eligible. That's how simple way I could answer.
I think that's a short answer, madam. Yes, thank you.
Yes, I agree with you, Adi. Agree. Yeah, Adi and Srini, could you please more elaborate on PDGM 12 grouping model?
Madhuri, I think for that, it is like, if we have to elaborate again, it takes another session. Okay.
Yes.
So our main motto today is to make people aware of home health coding and what happens in home health coding. This is one lengthy topic that, it is included in the course curriculum for the home health coders. So if we have to elaborate, then, probably it might take close to 3 to 4 hours just to give an intro and, make people understand what it is.
Okay, so like we will plan for another session in detail, another session continuing to this. So mostly
probably Madhuri, people can come up with their questions and give the questions because in the chapter meetings we are trying to bring the awareness of new specialities where people have too many questions in their mind. How do we resolve them and how do we help them? But we might not be able to do the complete education in 2 hours time. Okay. Definitely would love to answer all the questions. Please have team reach out to me and Srini with their questions. We will definitely respond and publish those questions in the LinkedIn as well. Okay. Yeah. And apart from that, if they need any information, we will definitely try to, bring it up here. If people want another session, we would love to do that, but let them be very specific on what they would like to know and understand in the next session.
Yes.
Okay, Adi, sure. Yeah. So, Adi, as we see most of the freshers join this call, would you like to give any career guidance for them?
Oh, definitely. So anyone, okay, welcome to the industry for all the certified freshers here in this group. Guys, only one thing that I would say, coding is not a job. I've been practicing coding for the past 25 years now, and I still learn anything new. And then until I practice what I have learned, I can't master it. So coding is a profession where you have to practice throughout your career. Keep learning. Don't think that, okay, I'm a certified coder and my job is done and I'm going to get my job and it's 9 to 5 or 9 to 6. No, it is not. This profession requires a lot of learning, lot of practice, and you always have to be inquisitive every day. The similar way where the physician have to read through and go through all their knowledge and revive their knowledge, rejuvenate every day. It's a similar practice. And the only thing when we practice coding, we have to be a learner every day. So there is a child in us every day that comes up with a lot of inquisitive questions. Imagine a child coming to you and say, why do we do this? What's the purpose of it? Similarly, every coding scenario that you come across, ask. Keep asking questions. Try to get answers and don't get satisfied with what you're getting. Keep learning, keep practicing.
Thank you so much, Adi, for the advice. As we see many freshers, they are completing their certification, but they are ending up with searching for the jobs, and few they are not getting the jobs even within 6 months. So would you like to give any suggestions for them?
Guys, getting certification is the first step. where, remember, there is a big museum, and to open the museum, CPC is the ticket for you. Okay, the doors are open. Explore the museum, and you need to take all the steps to explore the museum. I said a museum because medicine, anatomy, hospital, all the different specialties are all the coding. So you have to keep exploring, keep learning, and imagine, why are you not able to getting into the job after certified? It is because if you have given any interview and still failed, that means your knowledge is not enough for you to get into the first step. Go through all the guidelines, prepare well in the subject to answer, to get on to your job. If you clear the job, you have a job. Guide industry needs a lot of coders. If someone says, oh, I'm certified, but I didn't get the job, that means your knowledge is not sufficient enough for you to get into the job.
Yes, Adi, like we do observe a few coders, they are clearing the certifications, but they are not aware of what is coding guideline, how to implement the coding guidelines in real-time coding scenarios. And
Okay.
few, they are not good with anatomy and physiology. So as you mentioned, they should have strong knowledge and they should explore the things, and they have to spend more time on learning to have a better future.
Correct, correct. And Madhuri, for all the freshers, probably in my next presentation, which is going to happen on April 5th, correct?
Yes, Adi, yeah.
April 5th is our next event. And in that event, after my presentation, probably I'll have 30 minutes, where I will probably come up with some information for, especially for the freshers and for the coders who want to cross-train themselves and, scale their knowledge up. Probably I'll do another 30 minutes of the.
Great, Adi. Yeah. So we can take
One advice from my end also. If you are a fresher and you got certified and you need a job, so I would suggest instead of waiting for, so nowadays even we are getting queries like I am a certified fresher. I need an opportunity on E&M. I need an opportunity on surgery. Do we have anything like that? See, as a fresher, you need a job. You need to get into some coding job. Do not think about the specialty. That is my
Correct.
dearest advice to everybody who is a fresher and certified. So if you got an opportunity, get into the industry, and then you can just switch over the specialties, or you will get the opportunities. Many organizations cross-train people within their organization and give the opportunities in other specialties. So you don't need to worry about it. You just have to grab the opportunity first. So that's
And one more thing, don't think about, I need job only in this place. I need job only in that place. All certified freshers standing out here, if you are really looking out for a job, share me your CV and I will put through you to the interviews. This is an open opportunity that what I can offer. If you're a certified fresher, share your profiles too. But remember, don't think about the location. Think about how you're stepping into the career, how you're exploring your career, and how you're practicing in your career. That matters a lot for everyone. And everybody has our local chapter officer's number. Funny, if you would, Srini, if it is okay, if Funny can give you a personal number. Or Funny, you can present each chapter officer's number now. Let people take down each officer's number. People can reach out for any kind of a clarification. Exclusively for home health, why I said Srini and me is because we both have extensive experience in home health.
Yeah. Sharing the reports.
Yeah.
So everyone, you can even get these details from the page, from actually from the local chapter page itself. So I'm just sharing my screen. Give me a moment. So you're all able to see the screen. So you have all of our email IDs and contact information. So,
And we would love to do another event maybe in the month of May, because April 5th is already scheduled. If people have too many questions, so we can actually create a Q&A on home health coding exclusively in the month of May, which me and Srini can take it.
Yeah, we see a lot of questions in our chat box, so we will address those questions while publishing the presentation. If required, we can also schedule another session, especially on home health care Q&A.
Yeah. There is one question here, Aarti Bhosle. Can we change specialty from HCC to home health coding? You can absolutely take it up. There are so many HCC coders now making their career into home health. We have many who does that.
and so we also have got question on CEUs. So I think Divya, Macha, and some others also mentioning about not getting CEUs. See, guys, we have clearly mentioned the attendance criteria. So there is an attendance criteria. So you need to be there for at least 90% of the session in order to get the CEUs. So even like we are considering to give the CEUs as early as possible, it would take at least 4 weeks from today to credit the CEUs. The same thing happens for the previous sessions as well. Okay, so please do not worry about the CEUs for 4 weeks. We will definitely add if you are attending the session completely. So attending it completely is very, very important. If the attendance criteria was not met, then the attendance will not be like the CUs will not be provided. So that
and
is
also the timeline, funny. See, guys, there are close to 3,000 and 3,000 plus attendees who are joining. And to mark the CEUs, we definitely need some time, because we'll have to validate your attendance, we'll have to validate your time. So technically, it takes 3 to 4 weeks time, but we are trying our best to make sure that, people do get their CEUs within a couple of weeks. But after 3 weeks, if you don't get your CEUs, please reach out to us. After 3 weeks, I'm telling you, you might get, even by end of the next week also, you might get it. But wait for 3 weeks for you to get the attendance. If not, please reach out to us.
Thanks for that. All right. So I think we are almost at the end. Madhuri, we are done with the questions. And if there are anything, I think we can take it up and address them separately while publishing. So
yeah, mostly we have covered all the questions. There are 2 to 3 questions we have to address. We can address those while publishing the presentation.
thank you so much. So a big thank you to our very own chapter officer, Mr. Srinivas, for today's insightful session on home health coding. Your clarity on what you have given and the additional information that you have provided about the new department, I would say on nowadays, it is kind of a new opportunity for many of the coders who are looking into getting into the coding, right? So thank you so much for the valuable session that you have provided. And to all attendees, so thank you for spending your Sunday morning with us. So you continued your participation till end, and it keeps us our chapter active, informed, growing, motivating for us to conduct more sessions like these. So before we wrap up, a few reminders. Follow our AAPC Hyderabad LinkedIn page for event updates. We will be posting our event updates and any insightful informations over there. And join our WhatsApp channel. I have already provided the link in the chat box with everybody. It was shared with everybody. So please follow the WhatsApp channel, open the notifications, so that you will hear about next session when it is happening. But I have an update, as Adi has already mentioned. The next session is on 5th April on Saturday, 10 a.m. Mark your calendars. And this session is on primary care physician coding. And so this a different level of coders perspective will be set by, again, by Adi ma'am. So we have got overwhelming response on the previous event where we talked about, Adi has addressed about AI in denial management, and here she come again with a lot of inspiration and a lot of information and experience onto this. So the PCP coding based guidelines. So this session will explore a lot of real world scenarios and best practices in the primary care physician coding. So a must attend for coders of all specialties, I would say. So we have already shared the details over there in the chat box and also in our channels as well. Please do register and attend the chapter. Attend the chapter events again and again. Thank you so much to everybody who is attending, and thank you so much to my fellow chapter officers for your coordination, dedication, and hard work for making this thing happen. Thank you, everyone. Thank you, ma'am.
Thank you, Shahid. Thank you, everyone.
Thank you, Fanny. Thank you, Srini.
Thank
for the
you.
valuable
Thank you.
insights.
Bye-bye, everyone.
Thank you. Thanks, everyone. Happy learning and happy practicing, guys.
Thank you, ma'am.